I am going. Okay.
Yeah, so first of all, thank you very much for inviting me to give this Allen webinar today. I'm Lars Bullinger. I'm a hematologist oncologist working in Berlin at the Charité. And the title you told me I should talk about was how the risk classification in AML is driving treatment intensity. And I think this is a important title, or why are we talking about that topic? Because recently the risk classification has changed. Before I start, I also have some disclosures. So with regard to the different AML subgroups, I think that community, I think many of you are in acute myeloid leukemia, right? But for many years, we know that different molecular aberrations are linked to the outcome of patients. Acute promyelocytic leukemia, which was in the old days one of the most deadliest cancers, can now be treated with targeted therapy with all-trans-retinoic acid and arsenic trioxide. Those patients are now equally doing well than core binding factor leukemias that respond very well to chemotherapy. But then on the other hand, we have these leukemias, especially those with myelodysplasia-related changes or therapy-related AMLs, where only a minority of patients can really be cured and lives very long. But here, of course, you have to see that's very old data, but this is still the case today. And the question is now, how can we improve treatment here? And there, especially the new classification can perhaps help us to make decisions whether people should rather be intensively treated or less intensively treated. So in the past, those high-risk leukemias were defined by the presence of multi-lineage dysplasia. So this was a diagnosis that was still made by the hematologist by looking through the microscope. This is now gone in the new one. We put more effort on more objective criteria, as were already included in the old classification, MDS-associated cytogenetic abnormalities, but now there is also molecular abnormalities included, and of course a history of a previous myelodysplastic syndrome or myeloproliferative neoplasm is also still defining AML-MR, how it's now called, and the therapy-related leukemias, that group more or less stayed the same. So that means that you basically have a secondary malignancy that is originating on the basis of a previous anti-cancer therapy, very often where people have received radiation therapy or chemotherapy, that is DNA damaging therapies. Now we have a new WHO, World Health Organization classification from 2022. Here comes also into play whether you had a prior cytotoxic therapy. This is how it is now called, AML-PCT, which was the therapy, or TAML in the past. And then, of course, you have also these recurrent genetic abnormalities that define the leukemia subtype. Here comes also into play whether you had a previous myelodysplastic syndrome, yes or no. And then those high-risk leukemias are now not only defined anymore through the cytogenetic abnormalities, but also through this list of gene mutations that are frequently found in MDS, and that clearly show us now that the leukemia was originating on an MDS clone. And this can also be that, for example, the MDS clone was not detected in the past, but nevertheless led to the transformation into a leukemia. So this is where now these high-risk leukemias that really deserve our special focus when we decide on how to treat them would end. Then there is, to make it a little more complicated, also a new international consensus classification. This is a second group, mainly driven by hematologists who were not so happy with a classification that stemmed from the pathologists. Basically, it's also based on cytogenetic and molecular genetic abnormalities. The AML with recurrent genetic abnormalities are more or less identical to the ones in the WHO classification. What is new here is that the ICC is defining a cohort of leukemias with mutant P53. This is very often cases that also come along with a complex karyotype. And then if this is not present, then the molecular genetic abnormalities that are linked to MDS come into play. Then the old MDS-related cytogenetic abnormalities, and if they are not present, then the diagnosis is still based on morphology. And what's also different to the WHO classification is that not only cases with over 20% of blasts in the bone marrow are called AML here, we also have now this new subcategory MDS/AML if the blast counts are lower, but then that offers you the flexibility to either treat patients like an MDS or an AML. And if you look at that classification, those high-risk leukemias would now be located in the mutant P53 cohort, or that covers most of those already. If no P53 mutation is there, then also the presence of these MDS-related abnormalities or the cytogenetics themselves can make the classification of this high-risk group. And then, of course, they also can get these labeled therapy-related or prior MDS related. Then the classification was not only refined, but the increasing knowledge of these aberrations is also now has entered also the new risk stratification. This is where we use the prognostic information and the predictive information from these mutations. And here now, not only complex karyotype is considered adverse, but also those gene mutations that point to a previous MDS are included into the new risk category. P53 was already in there in the old one, ASXL1 and RUNX1 were already there, but then 7 new mutations were included into this group of AML with myelodysplasia-related genomic abnormalities. And how does that now influence our decision-making, or why first of all, why were those, that new category entered into this high-risk leukemia group? This is data that a publication that's lying back a couple of years that looked also at clonal evolution from Ben Ebert's group. And while it showed that you have these secondary type cytogenetic abnormalities, also de novo AML with these gene mutations, they do equally poor than the old-termed secondary AML. And the same is also true if you compare these secondary type AMLs with these MDS-related abnormalities here, shown in blue, compared to P53 mutant leukemias. They're equally doing equally poorly, and this is why that category definitely belongs into the high-risk leukemias. And we also looked in our data that we had published already now also 7 years back together with Peter Campbell's group. At that time, we didn't say that's myelodysplasia-related changes, but those gene mutations that often have to do with chromatin modifications or spliceosome, that's 50-50. 4 of the new genes that are in the classification are chromatin modifiers. The other 4 are dealing with how the genes are spliced. That means how they are translated and how proteins are made out of them. That group is also almost doing as poorly as the P53 mutant, definitely much worse than the intermediate risk group. And I think therefore it's well justified that this new cohort entered the high risk stratification. But what is now new also compared to the past, and while we for many years only had conventional chemotherapy, 7+3 scheme, cytarabine and anthracycline, and hypomethylating agents for older patients that cannot be intensively treated. Since 2017, we now have new targeted therapies and also especially new new formulations of the old chemotherapy that is more effective in these high-risk leukemias, that offer new treatment approaches, and therefore the risk stratification can also help you to decide or inform you how you should best treat the patient. And this is especially important as many of the patients which we see in the clinic are at this borderline age around 65 to 70, where many are biologically very fit, and you on one hand can still intensively treat them, but on the other hand, you also do not want to harm them by the therapy. And on the other hand, they are already old enough that you also can justify to not intensively treat them. But I think then the risk they have and also the chance they are responding to these new therapies should really inform also a little bit on how we treat the patients and what the decision should be. And this is now how we decide today based on the cytogenetic profile. On one hand side, you have to make, or say that's a critical, you have to define whether you think the patient is still fit for intensive therapy. That's the green, or the more reddish, more unfit. For the fit patients, we now still have the standard chemotherapy, plus in addition, we have some targeted therapies. For the prognostically very good ones, we add an antibody-based treatment that can improve the outcome. That's gemtuzumab, antibody against CD33 linked to a chemotherapeutic drug. For the FLT3, that used to be poor prognostic, the new tyrosine kinase inhibitors, which many know, it's similar drugs that we use to cure CML. If we add them to chemotherapy, they have now made this poor prognostic subgroup into an intermediate risk one. So that's a huge improvement. And for these high-risk AMLs, we now have CPX351, a new drug. Basically, it's a liposomal formulation of the old chemotherapy, but therefore it's working better. It's getting better into the bone marrow where the malignant cells are residing. And this is now improving outcome tremendously in these high-risk leukemias. And it's working better in many of the high-risk ones as the new treatment alternative, which we now have for the unfit patients. That's chemo-free treatment, if you wish, with a hypomethylating agent and venetoclax, a BCL2 inhibitor that's restoring the capability of the malignant cells to commit suicide again. So it's restoring apoptosis and thereby contributing to better control of those leukemias. But as I had mentioned, when patients come in newly diagnosed with leukemia, many suffer from the symptoms that really the acute leukemia is causing. They are immunosuppressed, they come in with fever, they have infections, perhaps bleeding due to the low platelets. But you really have to tease out whether all this just began because of the leukemia, and prior to that they were fit and healthy, were still hiking and doing other things, or whether they already were not very well even before the leukemia started, as they have comorbidities, sick heart. Then of course you would rather favor non-intensive therapies, and the others you would rather treat them like younger patients. And why is this now becoming important? Because, as I had mentioned, for these high-risk leukemias with AML, MRC, or therapy-related AML, we now have this new compound CPX351. This is also recommended by the European Leukemia Net guidelines, which is doing a very good job in these high-risk leukemias. As I had shown you in the very beginning, many of the patients that have these high-risk abnormalities die of the disease very early. This is what these survival curves show, right? At the beginning, all the patients are still alive. Then if you have this really high-risk leukemia that doesn't respond well to conventional chemotherapy, that's the orange line. Many patients die within the first year, and very only few patients survive longer than 3 years or 5 years. And the new compound, this is now CPX351, is also doing not a miracle, unfortunately. If you think of curves which we are used to with CML, where you now can cure almost all patients. But on the other hand, it doubles survival in this high-risk group. And the high-risk group accounts for a third of the patients. So for a third of the patients, at least, that means that the chance of living longer is now doubled. And it's especially the patients, the younger, fitter ones, when they are intensively treated, that can be moved forward to an allogeneic bone marrow transplant that have the hugest survival benefit. And here, over 50% of the patients are still alive after 5 years. So here you also can double outcome from a fourth of the patients that usually had a benefit from allogeneic transplant now to over more than half of the patients. And this is especially important as we now also can transplant patients who are 70 and older, that you keep that in mind. And many of the older hematologists, for them, the transplant border was in the old days, it was 55 or 60 years. And then you say, okay, if you're over 60, we are not going to transplant you anyway. Then you also don't need intensive therapy. We rather give you the low intense therapy. But then, of course, you can also, not do only good to your patients, because one of the problems is that especially the new backbone for the older non-intensively treated patients, venetoclax and azacitidine is working well and also in the good and intermediate risk, but not very well in these high risk leukemias where we thought that they might do well. And then this is data just showing that it's not only working well in these old MRC-defined cohorts, but also in the cases that have these new MDS-related gene mutations, the new drug. So that's definitely a good treatment option if the patients are still fit for intensive therapy. And this was also interesting to me. That's a very important study that was published 2 years back in Blood, where patients were asked with newly diagnosed AML in a prospective multi-center trial, irrespective whether they receive intensive treatment or non-intensive treatment. So you see here, it was of course not a very large trial, or it was a large trial with over 600 patients, but that even for patients that receiving non-intensive therapy, the main goal of the therapy should still be to cure patients, right? And I think this you also have to consider that most patients with acute leukemia do not worry so much about little more side effect, perhaps, but they rather want to have the chance of being cured. And therefore, I think this also should go into the treatment decision approach and has to be clearly discussed with a patient. And then, of course, you can say that the data I showed you for the more intensive therapy, that this is giving you this benefit in the older patients also. This was, of course, a phase 3 clinical trial to approve the drug. We all know that very often you have some bias in these studies. So what is becoming more important is that we also look at real-world evidence, at real-world data, whether then if we treat our patients in a daily clinical routine with these new drugs, do we really see the same thing? And this is now data that comes from German, French, and Italian groups that looked at the use of CPX351. And what you can see here, that the data hold true, that we can control the disease very well in over 50% of the patients. You have response rates in the range between 50 and 60%. Complete response rates, which is very good in daily practice. And the other thing is also what these data show, I think I forgot to put in the slide, that the more intensive therapy is very well manageable. It's not causing, for example, more infection-related deaths or early deaths. So that's important. Yeah? And then that also translates into very good overall survival curves. Of course, these data have to be interpreted cautiously because those real-world evidence data do not have a long follow-up yet. And it's retrospective data, often from only one center or few centers, but nevertheless, all the curves show definitely much better outcome than we are used to seeing in this high-risk group in the past. And the data from Germany also shows that especially the patients that then can go into a transplant, that in those patients the outcome is really good. And I think these curves are promising that these 50% outcome or long-term overall survival can be reached. And here also many older patients were included into the transplant protocols. So I think this is an option one definitely has to keep in mind. And the reason why we think that we do better with this intensive therapy, I think the intensive therapy can better control the disease, that we have more patients in which the disease is so good controlled that at the time of transplant, they are really negative for measurable residual disease. And then the new immune system, which you get from the transplant that cures you, really has enough time to develop its potential to eliminate the still surviving leukemic stem cells, and therefore we can cure more patients. And then in the end, also wanted to show you that while venetoclax and the hypomethylating agent is doing much better than hypomethylating agents alone. So that's the green versus the orange curve. So you really can improve outcome. If you look at the high-risk ones who have these P53 mutations, that's the purple curve versus the red curve. It's not improving outcome in these high-risk leukemias that often have these secondary AML changes, these complex karyotypes. So I think in those really, if patients are fit for intensive therapy and in whom an allogeneic transplant is an option, I'd rather would go that way. If they are not fit, of course, it's still a good treatment, definitely not worse than what we had before, most likely also not much better. But the goal for these patients would then be, of course, to include them also in clinical trials, where we now even add to venetoclax and hypomethylating agents, new immunological treatment approaches, checkpoint inhibitors, new that can also then improve further outcome in these patients. On the other hand, what you also have to consider, once in a while you think a patient is not fit for intensive therapy, you start him on that combination. Response rates are as good as with CPX-351. The problem is only that they don't hold as long. But nevertheless, if someone isn't in a complete remission and suddenly does much better than before, then even reconsider here an allogeneic transplant, because as you can see, that combination is improving the time you can control the disease, but you're not really reaching a plateau. The curve is also going down. That means with that combination, especially in older patients, you can improve outcome by prolonging survival, but we do not really cure many patients with that. And therefore, if you control the disease, patient gets better and allogeneic transplant might become an option. Then also, even if not intensively treated at the beginning, that's still an option in these patients. And this was my brief summary. I hope I could show you that now we have this new risk classification. I think for the intermediate and low risk patients, doesn't really make definitely we have these new targeted therapy approaches if they are younger. For the older ones, the hypomethylating agent plus the venetoclax works really well. And if someone is 72 or 73, that's a good way to move forward. But if they have high risk abnormalities, really carefully evaluate whether they nevertheless could be intensively treated, and allogeneic transplantation might be an option for them, because then you really can double outcome and also long-term survivorship with more intensive treatment strategies as compared to the standard backbone. But if you have to use the standard non-intensive backbone, still keep in mind that transplant can become an option if you have controlled the disease well. And then, of course, also think of clinical trials for these high-risk patients where new substances are added that bring in also an immunological treatment component in older patients. With this, I'm at the end, and I'm happy to take your questions.
Super, thank you so much, Lars. It's been a very interesting presentation, and also seeing that progress is being made, even though we all hope that at someday the AML curves will be up there.
Like CML, yeah, that's still a long way.
Like in CML, we can say this is still a long way, yeah. So thank you so much for, let's say, holding the flag up and doing so much research in AML, which we see is badly needed. There were a couple of questions that came in. One was from Giora: is AML post-myeloma similar risk like post-MDS or MPN?
Yeah, all these secondary malignancies after previous chemotherapeutic treatments have an equally bad prognosis, yeah.
Right. And then Stefan was asking, what's the trigger for fit or unfit? I'm not 100% sure where this came up during the presentation, but you probably know where.
It wasn't slide on the top. You showed a green bar and a red bar.
Mm-hmm.
What type of treatment the patients received?
Yeah, so the fit and unfit, that's always this tough decision, right? I also had that one slide that helps you a little bit to make the decision. So there is also these frailty scores you can use. The transplant people have scores that predict the risk when you go into an allogeneic transplantation. That helps you a little bit. But for me, the most important thing is experience, a little bit gut feeling. If you see someone, do you think that's a person that was like still quite fit before the leukemia hit that person, or whether it was a person that already had many problems even before the leukemia started? Why do we have to consider that? Why do you just say, why not treat everyone intensive and see how she does and then go from there? The intensive therapy has a little more risks with regard to infectious complications. It's more strenuous for the cardiovascular system. If your heart is sick, that can cause problems. And you, on one hand side, want to make sure you really cure the patient from the leukemia, but on the other hand, you also do not want to kill the patient with a too intensive treatment, right? You do not want to harm the patient. And on the other hand, you also have to consider the chance that the intensive therapy really will bring you a large enough benefit that justifies that slightly increased risk you have with this more intensive therapy. In the past, the classical 7+3 didn't justify that benefit because you didn't really have the outcome benefit. You only had the higher risk of being intensively treated. This is why then many said, okay, then in these cases where we are not sure if they have high-risk leukemia, then let's just use venetoclax and azacitidine. But on the other hand, with CPX351, you now have a good option for these, and you also should use it, because then you can really cure more patients. And there's also a slide I forgot to bring with you. There is a cohort there was an American study that looked at P53, these high-risk mutant leukemias, and could show, since azacitidine and venetoclax became available in the US and was then also used on many of these high risk, because people thought conventional therapy is not so good and CPX351 was not well known, that the survival even got worse because you treated less patients intensively and moved forward with less patients to allogeneic transplant. So yeah, sorry, it made it little complicated, my answer, but I think you have to be very cautious in your decisions making.
Thank you so much, Lars. Geissler wants to ask a question. I've given you unmute rights, Geissler, so you can ask your question now.
Thank you for the unmute and thank you for the presentation, Dr. Lars. A question, not directly related to the topic, but patients who are even in a higher risk, let's say patient who has been with AML and did all the treatment, the chemo, and went to a transplant, and now has a relapse of AML within about 6 months, which is probably higher risk than before. What is the CPX 351 or any other treatment options available for such patients?
Yeah, that's a tough question in a way. That what do we do when patients relapse after transplant? If it's already within half a year, then depends on what they have received before. CPX 351 very intensive. I would only use if there is the option to transplant them a second time. But after half a year, that's very early. Then usually you would not do that. Then I would rather go for some less intensive therapy. So venetoclax and azacitidine, if they have not received that before, is a very good option post-transplant, because what that then can do is not only have this direct effect on the leukemic cells, it will also indirectly stimulate the new immune system from that you have received from the transplant that is still around, and can improve that anti-leukemic effect the new bone marrow has. And they together can even have the chance to control the disease again if you start the treatment early enough. So that's one of the things we would do. And then the other thing is you can also then always look at the leukemic cells again. Very often they also can change. They can acquire additional mutations. For example, ID8 mutations can come up, or FLT3 mutations, for which we now also have specific targeted treatments that can be then added in the relapse setting.
Okay, thank you.
Thank you very much, Lars. I have one more question. I mean, thinking a bit about real world and choices that patients can make. I mean, the problem about AML, if I understand it right, is that patients between diagnosis and start of treatment, there's not much time. It needs to be very quick. And I mean, in a center like yours, of course, you got the whole, breadth of things that you can do, but you were outlining these new novel agents in 2000 that came up after 2017, venetoclax, CC486, and a couple of others. What about, let's say, how do people choose with AML, given they're being hospitalized somewhere very quickly, and then probably need to take these decisions relatively quickly, or need to do diagnostics probably to even get access? What's your perspective as a global researcher, how this works, and what's the reality for patients out there? Can they access that? Is broad access there?
Yeah, so that's also, it's a couple of important questions. So informed consent in these very traumatic situations where the disease can hit you very quickly, it's of course more difficult. What patients themselves can do, or what you definitely should always go to centers where they treat many patients, right, where they have the knowledge. Then with regard to access to these new drugs, that of course varies quite a bit in Europe. Germany, we are of course fortunate that the healthcare system still pays many of these new drugs. But I think for most of the Western European countries, you have access now to CPX 351 also. So I think at the beginning, the best thing is to go to a huge center, especially to one that participates in the large cooperative trial groups, which you have in all large countries. Then very often especially the disease in older patients, it comes a little less aggressively than in younger ones. In younger ones, very often also things are clear. They have these lower or intermediate risk karyotypes, especially if you, for example, have a preceding history of MDS, and then the bone marrow is very often showing between 10 to 15% plus. People are already discussing, is it already an AML or not? I think then you still have enough time to think about whether you would want to have the risk or to take the chance to get a transplant, or whether you would stick with non-intensive therapy and get informed. I think we already perhaps have to educate the MDS population and MPN population already a little better, what then can suddenly hit them if the leukemia transforms. And then already at that stage, perhaps seek also a secondary opinion with a center experienced in also giving the transplant, because they only can tell you what the risk of a transplantation is, and then perhaps talk early to these and make the decision yourself upfront whether you want to do that or not at the time of transformation.
Thank you very much. And then one more question, probably more research related. I mean, you've been one of the pioneers also in Harmony, which is one of the biggest big data projects in Europe, where you're trying to consolidate all the different data from AML patients into a huge database, and then you can actually much more detect like prognostic factors or whatever on large data sets. So what were your learnings from that, as we've been talking about predictive factors and prognosis and so on?
Mm-hmm.
Have you learned anything new about that? What is happening there on that kind of prognostic front?
So there we already have learned a lot from putting the data together, and it also taught us that we should not stop and collect even more data. So one project where we only looked at the last 20 years, and we divided the data into 5-year bins and had a look how patients did in like 20 years back, 15 years back, 10 years back. And there we already could see a tremendous increase in outcome, despite the fact that the new drugs were only approved in 2017. And that taught us that we were doing much better, for example, in controlling side effects from transplant, that we have better drugs to cure infectious complications. There is better antifungal drugs, better antibiotics, there's better immunosuppressants. So we are doing much better with that regard. And then it also taught us a lot about this heterogeneity, that, for example, the intermediate risk group with NPM1 mutations can also be discriminated in ones who'd rather should go to transplant, whereas others where you will never need a transplant. But now what we have to continue is to collect also information on these new drugs. And there the data is still too sparse to then also allow these subclass analyses. Moderna, for example, has shown a nice analysis, which is in part also related on Harmony data, showing that, for example, this risk stratification, which we have, only works well for intensive therapy, but it's not predicting response very well to venetoclax and azacitidine. There, the genetic markers based on different genes are important, like DNMT3A, DDX41, and FLT3. So we have to continue to learn, but on the other hand, it already showed us that over time we can do those intensive therapies much more safely also in older patients. I think this is important now also when you think of these new treatment options, that we do not have to be afraid anymore of transplanting a patient when he is 72, if he's fine, more or less. Yeah.
Thank you so much. And I can see Stefan has his hand up. So Stefan, do you want to raise your question?
Yes, so I'm patient. I was diagnosed 5 years ago and received stem cells transplantation. If I understand it right, if today's patients have a adverse risk, they still go for the path to receive a stem cell transplantation. And the CPX drug only will help more patients to get to the level that they can receive a stem cell transplantation, or will it be so good that they don't need to have a stem cell transplantation?
Yeah. No, this slide I also kicked out. It's also improving survival in patients when they then do not undergo a transplant. It's also doubling outcome in them. But then the chance that you relapse is much higher than with a transplant. The problem is always in these high-risk leukemias, there's always leukemic stem cells that somehow persist, and you need that immunological treatment component. So you really need that either new immune system that can cure you, or you somehow have to find ways how you can activate your own immune system again to eliminate those leukemic cells. And for the patients that cannot undergo transplant nowadays, we for example have now trials with checkpoint inhibitors. That means that, for example, we know that the leukemic stem cells have markers on their top that tells the immune system, don't eat me. And now you have antibodies who can cover these don't eat me signals, and then suddenly the immune system can attack the leukemic cells again. This is what we hope that can help to overcome this resistance in p53 mutant leukemias. And I think there we will see many more treatment approaches, such as, for example, also CAR T cells for leukemias, that we can really control the disease better, also in older patients that cannot undergo transplant. But you're completely right with CPX351, the biggest benefit and really that large improvement in curing patients is for the ones who then can undergo transplant.
Okay, yeah, thanks. And so the new diagnosis where you look into the genes in more detail, it's basically you're putting more patients into the adverse risk because you better understand on the risk.
Yeah, so there is a couple of there is a little more patients who have that adverse risk. That's correct. Yeah,
because it's in greater detail now. It's a better understanding when I just opened my thing, and for me it says just del5q and trisomy 8 and 9. And nowadays, if I would have the same diagnosis, there would be say a longer list perhaps on things that are wrong in my body.
Yeah. So, and that for example then can again help you make the treatment decision. In the past you would have said, oh, patient has an intermediate risk, then I'd rather go not for transplant. But now you know, okay, this patient really should go to transplant if he can. Then also the treatment decision making is a little easier. The largest problem we have for these intermediate risk patients, right? I mean, for the good ones, it's clear they don't really need it yet. Yeah. For the very poor ones, it's also clear they should go, but this intermediate group is always making our life hard. And now you can split that a little better. Yeah. And this is what I understand.
Where is it? So it's only the good ones and the bad ones now, and the intermediates one getting smaller with a better diagnosis.
Yeah.
Okay, thanks.
Okay. I don't see any further questions. I don't know if anyone has a last question from the people on the call.
For me, not. So if we receive the slides on the webpage later on.
Yes. So we'll have a recording of the webinar on the website, so you can also go back and listen again to Lars' presentation. And well, with that, I'd like to thank you, Lars. This has been really interesting. Thank you again for pushing research in AML forward. I think that's really, really important to us, and for Harmony and for all the good things that you do. And thank you for being with us today. That's really great.
Thanks again for the invitation. And also what I learned a lot from Harmony is that we should work together also much closer, right?
Yeah, absolutely.
That we speak all the same language.
Yes.
Good. Okay.
Super. Thank you so much.
Danke.
Talk soon.
You.
Danke.
Bye-bye.
Bye.
Bye, everyone. Bye-bye.